on this topic from different perspectives. I'll start with my introductions. Dr. Mohan Belthur is a member of our Phoenix Children's Orthopedics Division. He's passionate about teaching, mentoring, and connecting, whether with patients and families or other health professionals. He's also involved in clinical research and global health. He works with nonprofit organizations focusing on easing the burden of childhood musculoskeletal disorders in low and middle income countries. When he's not working, Dr. Belthur enjoys a range of activities and recently received his black belt in South Korean martial art of Tang Soo Do. Next is Dr. Melissa Esparza. She is a pediatric orthopedic surgeon at Phoenix Children's who cares for patients with musculoskeletal injuries or conditions such as genetic deformities. She attended UC San Francisco for med school, residency at the University of Arizona in her hometown of Tucson, and a fellowship at Texas Scottish Rite Hospital. She is excited about teaching and mentoring and also has an interest in global health and addressing health disparities locally and internationally. Outside of work, Dr. Esparza enjoys spending time with family, friends, traveling, and other outdoor activities. Next is Laura Graziano. She's a pediatric physical therapist working in our outpatient rehab at Phoenix Children's. She treats patients from birth to adulthood and is passionate about empowering both her patients and their families to optimize participation and function in their daily lives. She received her doctorate in physical therapy from Northern Arizona University in Flagstaff. And when she's not in clinic, she also enjoys being active, traveling, and spending time with family and friends. Finally, Jillian Okimoto is a certified prosthetic orthotist at Hanger Clinic in Phoenix. She has more than 14 years of experience in the field and specializes in the lower extremity. She is passionate about custom fitting devices that help her patients reach their goals, from playing sports to keeping up with their friends. She's also committed to educating parents about the complexities of prosthetic devices, pushing patients to expand their goals, and celebrating milestones during their care journey. Outside of work, Jillian rides motorcycles, enjoys photography, and volunteers with Camp No Limits. We'll take questions for all presenters at the end. As a reminder, there will be no CME credit offered for today's talk, but as you know, knowledge is the best form of credit there is. Please enjoy today's presentations. Thank you.
That forward, so not advancing. Oh.
Yeah.
Okay. So hi, good morning, everybody. I'm Dr. Mohan Belthur.
Melissa Esparza. I'm Jillian Okimoto. I'm Laura Graziano.
So these are our learning objectives. I'm going to leave it there for a few seconds for you guys to read. I'm not going to read it for you. Thank you.
So as we look at the epidemiology in the pediatric realm, acquired limb loss is less frequent than congenital. In 90% of the acquired cases, only a single limb is affected, and it's typically 60% of that is going to be lower extremity. If we move over to congenital, upper is usually in a ratio of 2 to 1, and actually more recent literature indicates that that might be closer to 3 to 1. You will also see more multiple limbs involved in congenital cases than that of the acquired. When we look at treating these two populations, it's really different. When I have a congenital kiddo come in, I'm looking at associated conditions that might be involved, also soft tissue complexities. We also have associated things like maybe a deficient ACL, and how does that change my fit or my component choices? Whereas a trauma case might be a little bit more straightforward in terms of anatomy and soft tissues. They also have different goals between these two groups. So as we look at our congenital kiddos, they were born without. So for us prosthetically, anything that we need to make them is going to have to be an aid. If it doesn't aid them, then you'll see them reject that device, especially in upper extremity kids. If you have a hand and they don't have sensation anymore in that arm and they're capable of doing everything that they want to do without that arm and it doesn't aid a specific function, then they'll reject that. Where you look at the acquired kiddos and they remember before, and they remember everything that they could do before, and they want to return to that before. So if you don't deal with the psychosocial aspect of that, then a lot of times that's where you see prosthetic rejection. So we are going to talk through our multidisciplinary clinic for limb loss and limb difference. And we're going to utilize 4 of our cases later to discuss how we got to optimal outcomes or how we're working towards those optimal outcomes collaboratively.
So I think it begs a question, like why a multidisciplinary approach? So it's because, when you look at pediatric amputees versus adult amputees, there are different challenges that children and young adults face. And these include that you need to allow for growth, both in terms of length as well as girth as the children grow. Secondly, you need to allow for lots of comorbidities, like Jillian mentioned, when you have like an amputation from birth, it may be associated or at least part of various sort of syndromes. For example, like proximal femoral deficiency, where they have a short leg because the femur is short, they could have other conditions. Or, for example, yesterday I was working on a child with thrombocytopenia absent radius syndrome. And even though she has a deficiency of her leg bone, she also has thrombocytopenia and various other issues that come with that. Okay, so that's one issue. The other thing is, as the child grows, you need to account for their physiologic development. And then they may have challenges with behavior as well as psychological development. Okay, and also as children, they put a lot more demand on their prosthetics as opposed to older people or young adults, for example. So for all those reasons, the challenges are multiple. Therefore, you need an ensemble. That what I mean by that is, the function or the overall function of the team is better than the sum of the individual parts to take care of these children. And the purpose of the multidisciplinary approach is to maximize the function of the children and their quality of life by doing a multidisciplinary evaluation, shared decision-making involving the family, the child and the parents, and making sure that you optimize their function.
So these are just, a few of the members of our multidisciplinary team that are really important in treating these patients. So pediatric orthopedic surgeons like myself and Dr. Belthur, certified prosthetists, physical and occupational therapy. Also one bullet point we don't have on here, but that has been a specialty that's been very helpful is physical medicine and rehab, work closely with our PT, OT, and ourselves. Plastic surgery will go into their role in a little bit on another slide as well, but both for upper extremity amputations, we have our hand surgeons here, and for coverage issues, and again, some other issues we'll talk about. Pediatric surgery, I found that psychology has played a huge role, and Jillian kind of touched on the psychosocial aspects of care for these children. And so having patients meet with our psychologists both preoperatively and postoperatively can really help optimize the outcomes for patients, for families, and just helping them cope with this big life change that they have after the surgery. And then, of course, patient and parents, and really just having them involved in the decisions for care and really on board with that makes a big difference in outcomes.
Yeah, I think other couple of people we didn't forget, we just put physicians there. I think also it's very important that we have, like a medical assistant that's dedicated, social worker. It's very important to work with these families because they have lots of care coordination involved. We need a dedicated nurse coordinator, etc. So, and also like business administration, so they understand the business side of things as well. Thank you. So who are the ideal candidates for this clinic? Or so usually it's children or young adults who either have limb loss from birth or from other acquired conditions, or limb deficiencies where we cannot kind of restore their limb or reconstruct their limb. So there's two groups. So whenever you have limb loss or limb length discrepancies, you can either do lengthening or limb reconstruction surgery, or you can do prosthetic reconstruction surgery. So those candidates who are not suitable for limb reconstruction surgery would be candidates for prosthetic reconstruction surgery to restore and optimize their function. So in general, when you look at the pediatric population in the congenital, like Jillian said earlier, constitute about 60% or 2/3 of the population, and the acquired conditions about remaining 40%. And these are some of the acquired conditions that can result in limb loss or limb deficiency. For example, this is a child we're going to talk about later who had a gunshot injury to his femoral artery. As you can see the bullet there. And he developed, even though they tried to do reconstruction, he presented late to the hospital. And by the time we got to him, he already was developing like compartment syndrome and all his muscles were dead below the knee. So he ended up with a through knee amputation. This is another child with severe knee flexion contractures and in addition, arthrogryposis multiplex congenita. That means multiple congenital contractures. So he had to undergo like a knee disarticulation because we couldn't get his leg straightened out without doing that. And then this is a child with tibial hemimelia. Again, this is another thing where you need to be aware of other comorbidities. This is a child who had who was normal, and then she presented. She developed a bloodborne infection like streptococcal septicemia, and ended up on the PICU, and then ended up with ECMO, and then had microangiopathy resulting in peripheral vascular disease in all 4 extremities, and then resulting in multiple limb deficiencies. And this is a child who presented with a large tumor in her upper extremity, which turned out to be rhabdomyosarcoma. And then this is another child with a macrodactyly, that means an overgrown toe. So those are all some examples of indications. Now, what are the principles of prosthetic reconstruction surgery? I think these are a few principles. One is always try to preserve length. And as you know, children have growth plates. So try to preserve the growth plates always, because a longer limb provides a better and stronger lever arm, because the muscles attach to the bones and therefore the lever arm is better. And also when you sit, it allows for better balance when you have a longer kind of lever arm. So for both those 2 important reasons. And then the growth plates allows for growth. Okay. So sometimes, however, it may prevent, it may not allow space for prosthetic joint fitting. So in some patients, we may need to, actually ablate the growth plate at a particular time so as to create space for joints, for prosthetic joints, etc. And we always do that in consultation with the prosthetist. Okay. Then the other principle is always a disarticulation. That means an amputation through the joint is better than an amputation through a bone in a child, because as you know, the bones grow. So as the child grows, because of the remaining growth plate in the bone, and also because of oppositional growth around the periosteum of the residual limb, there can be overgrowth of the stump. So that can cause problems. You don't have those problems with this disarticulation. So that way we always kind of try to do disarticulation if possible. And then we always try to preserve joint function, because the knee acts as a shock absorber when we walk, and the hip and ankle act as power generators. So if we take away these joints, then it makes walking inefficient, and also more, it consumes more energy. So for both those reasons, we try to preserve joints as much as possible. And then we also try to stabilize and realign the limb above the amputation level, so that prosthetic fitting is easier to optimize limb function. Okay. And then also we need to look at some other concerns. For example, in the congenital population, and sometimes in the they could have other comorbidities like syndromes, other genetic conditions, etc., that need to be optimized. And in the congenital population, they could have multiple limb deficiencies. Sometimes even in the acquired, like I showed you, the child with infection, she had both legs and arms. So we don't want to, we want to make sure we don't take off more of the limb that's remaining. So we try to think carefully, because sometimes even though the hand is prehensile, the foot is also called as a lazy hand. And sometimes, as you can see, this child here, even though she has phocomelia, she's using her foot as prehensile organ. So we want to be very thoughtful and intentional if we want to do something for her. Okay. So those are some considerations. Okay. So, and you need to be aware of some special surgical techniques in order to optimize function. For example, at the level of the ankle or below, whenever the indication is appropriate. For example, when you have an injury at the level of the foot, or there is an amputation at the level of the foot or the ankle, there are some special techniques that can be used. For example, a couple of them are called sign amputation, named after the person who created them, and Boyd. These are amputations at the level of the ankle. For example, this picture shows this red line is the level of the amputation. This is a Boyd amputation. In this, amputation is at the level of the ankle joint, but you preserve the calcaneus, and then you kind of prepare it and then attach it to the distal tibia and fibula so as to create a wide base and stability for the heel pad, because the heel pad is a special structure. So that gives more stability and makes the residual limb better functioning as an end-bearing stump. So these are some special techniques that you need to be aware of. Okay. Whenever you're forced to do a transtibial amputation, which we try to avoid doing, but sometimes you may be forced to. For example, when you either have a congenital amputation at the level of the middle of the tibia, or when there is a traumatic amputation, then you may have to do this. So in this case, what this child, he had a synostosis between the tibia and fibula. That's called as an Ertl procedure. And this should not be done, because as the tibia and fibula grow different rates. And as the fibula grew, it caused this varus deformity. You can see the tibia is bowing now compared to before. And then you had to do this extra procedure to try to get it straightened out, as you can see from here to here. So you need to be aware of some things that you should not be doing and some things you should be doing. Okay. And then at the level of the knee disarticulation, even though in adults, you need to think about the soft tissues, like which flap, whether to preserve the patella or not, etc. In adults, usually because of vascularity issues, you usually create a long posterior flap. And in children, you usually want to do a long anterior flap because it has the prepatellar tissue, which is well adapted to walking and crawling and provides better stump. And also the scar, as you can see here in our patient, the scar is on the back of the leg, and which allows for better prosthetic fitting. It doesn't rub as much. Okay. And then this is called as Van Ness rotation plasty. This comes in handy in tumor cases, as well as when you have like a segment loss in the leg, or in congenital cases, for example, like a very short femur, etc. So you can make the tibia and then put it either at the level of the hip, or as in this case, there was a tumor in the proximal tibia, they resected it and then reattached the remaining part of the leg, converting the ankle into a knee. And then they turned it around such that the ankle can work as the knee. So that's again preserving joints for better function and creating a longer lever arm. So that's again a special technique. And then obviously transfemoral amputation here, again, you may need to be careful with the flaps, and you may need to cap the stump here with some ilia crest so as to prevent overgrowth. So those are some special techniques. Okay.
So this slide is actually provided by one of our hand surgeons, Dr. King. And just to kind of reinforce that multidisciplinary approach, our hand surgeons, Dr. King and Dr. Hassan, have been very helpful with a lot of our patients, both in, for upper extremity amputations, helping us with coverage issues, for example, in kids with traumatic amputations, if there is soft tissue damage, and sometimes a free flap skin grafting can be needed to get good coverage of the limb. They've been very helpful with that. And then there are some of these newer techniques for nerve transfers for amputations. So the overall goal of nerve transfer in the setting of amputation is to prevent neuromas, prevent phantom limb pain, and theoretically to help with myoelectric prostheses, particularly for upper extremities. With targeted muscle reinnervation, the nerve is sutured into a nearby motor nerve, and specific nerve targets for specific muscles will allow for that myoelectric control with a myoelectric prosthesis. Regenerative peripheral nerve interface is when there is not another functioning motor nerve to connect into. And so the nerve is dissected out into nerve fascicles and then basically wrapped into a viable muscle. So I have an example, a picture of this in one of our case studies, and it kind of shows these, what Dr. King called them nerve or muscle tacos. So just basically wrapping good muscle around the nerves to kind of give them the nerve something to do so that it doesn't have this phantom limb pain or neuromas.
Also, like I said, follow-up to skeletal maturity is required once you start seeing these children, because many of them may require additional procedures during their life. And these include something like joint stabilization and correcting deformity, like we talked about earlier. And then there may be stump overgrowth, like you see in this picture, where they did a transtibial amputation, and you can see that the residual bone is now sticking out of the stump, causing pain. And then whenever they load the prosthesis, it's causing pain. So we have to go back in here and then revise the amputation and cover it. In this case, we can either use a proximal fibula, turn it around, put it here, or we can use the ilia crest to cap this. And that's been successful in about, usually about 50% of children who have like a trans bone amputation will get overgrowth. It's more common in the tibia, because in the tibia, the proximal tibial growth plate is the growing end, and in the femur is the distal femur that's a growing end. So it's more common in tibia than in femur, and about 50% of them get it. And then this procedure, the capping procedure, which is shown here, where you take a piece of ilia crest or fibula, you put it into the medullary canal like sharp edge. This has been successful in about 90% of patients. And also, like I said, you may need to equalize leg length. For example, if there isn't enough space for prosthetic joint fitting and things, you may have to, intentionally ablate or shut down the growth plate. For example, in this case, the proximal tibial growth plate, to create space for the joint. This is usually required in the Syme or Boyd amputations, because both the ankles at both legs are at the same level. There isn't enough space to fit the ankles. So sometimes you may need to do that at an appropriate time in consultation with the prosthetist.
So this is going to be a recovery timeline for prosthetic reconstruction. I think what this is missing is that preoperative time period. And really that's the most important part. If we have that pre-op time, then we're consulting together as a team about what's going to be optimal for this patient. It also gives us a chance to offer that family and that patient a peer mentor. So we would bring in another child and their family to talk to that family and show them what that amputation looks like, what their prosthesis looks like. The parents get to ask that family questions. We also get to answer kind of all of their questions about recovery, give them a timeline so they know what to expect, so they're not going into this blind. But once that surgery does happen, we are sometimes present in the OR to take a cast, so that once they apply their cast and it's removed, we can apply a stump protector to the limb. Other times, in lieu of a cast, we'll use a stump protector. After we do that stump protector, there's that healing period. And once the child's ready for a prosthesis, then we would go ahead and get them fit. And then we transition them into the physical therapy realm so that they can move forward and start their rehab process. So if we look at principles of prosthetic design and application, really we're looking to stabilize that limb and also transfer all of the forces to the bony anatomy and restore structural support to the skeletal system. We want to provide developmentally appropriate components as they grow and start looking into additional technology as they're getting older and looking into additional sports. And we want to make sure that we're meeting milestones with their peers. The biggest thing at the end of the day is that we want to keep these kids active and engaged in their communities and with their peers. They already have barriers to access. And so if we can remove any of those barriers and keep them more active, that helps with that body acceptance. It helps with interacting with their peers. It helps with all sorts of different psychosocial aspects of this patient. So just so that we are all on the same page, I'm just going to really quickly go through like our terminology in prosthetics. So between the actual limb and that prosthetic socket that you're seeing at the very top, there's usually some type of interface. A lot of times there's either a sock or some type of silicone liner that's going to go between the limb and that socket so that we reduce shear forces, we give a little bit of cushioning, and we don't have skin breakdown. It also gives us the ability to adjust for volume changes, because sometimes there's a sock and we can make that sock thinner or thicker as they grow circumferentially. Then at the very top, you have your socket, and that's the part that the residual limb actually goes into. So we're targeting specific areas for compression so that we can hold up that bone and they're not walking through the distal end unless they're meant to, like in a natus articulation or Symes. Below that, on the right-hand side, we have a prosthetic knee joint. And then below that knee joint and below the socket on the left, we have our pylon, which would be considered our endoskeletal componentry. You do sometimes still see exoskeletal componentry where you wouldn't have that pylon, but it's not as common anymore. especially with kids because we want to allow for growth. And so that pylon allows us to lengthen the prosthesis as they grow so we can keep their pelvis nice and level. And then at the very end, we have our terminal device, which would be our prosthetic foot. The K-level system, if you guys work with any of these patients, is what we need in our documentation. It is Medicare's documentation for functional level. The K-level system works on a scale of K0 to K4. K0 is not up here because your K0 would be a non-candidate. So somebody where a prosthesis would actually be detrimental, or we could put them in danger, or we could lead to like severe skin breakdown issues. Usually somebody who's going to use a Hoyer lift, and it wouldn't even help them stand or transfer at all. If you look at your K1, that's going to be somebody who is a household ambulator. So in the house, they're going to use their prosthesis for walking around. They're usually going to use some type of assistive device, and they're going to walk at one speed. Once they get out of the house, a lot of times you're going to use a power mobility device or a wheelchair. They're not going to walk much outside of that house because they'd struggle with any type of environmental barrier. Then as you move to K2, that's going to be your limited community ambulator. They are still going to walk at one speed, but they should be able to navigate some type of environmental barriers, small ramps or slopes or stairs, but they might struggle with something like uneven terrain. They're still usually going to rely on an assistive device. So the biggest difference between K2 and K3 is your K3 can walk with variable cadence. They can change speed if needed. They can go from walk to jog. They should be able to hit all sorts of environmental barriers, uneven ground, stairs, ramps, slopes. And then your K4 is really where these kids often live. It's somebody who can exceed just normal basic ambulation, somebody with high stress. So usually construction workers, athletes, and children. For insurance purposes, I would consult with whatever prosthetist you're working with, because sometimes insurances scrutinize at K4 level and will deny things. And there really isn't any different componentry for us between K3 and K4. But this is kind of where in the prosthetic world, we've gotten in trouble previously. With our older adults who are diabetic and dysvascular. This Medicare system was created for soldiers coming back from war way back in the day. And so a lot of prosthetists have misused the word potential in this. And so the potential to return to prior activity is important with kids. They have a huge potential to return. In your diabetic dysvascular population, who are older adults, that potential to return to that prior activity is probably substantially less. Just like lower extremity, upper extremity has their own components. So you usually still have an interface in upper extremity. Sometimes you will not have an interface between their limb and the socket though, and it'll just hold on by skin suction. So their limb will go directly into their socket. You have your prosthetic socket, and then between the socket and that terminal device, sometimes you have a pylon if it's endoskeletal, but that's a lot less frequent. A lot of times that socket goes directly to that terminal device. And so you can either have a hook or a hand. A hook is a lot more functional than a hand, just because for being able to see or find motor skills, you can pick up things. It can also be controlled by two different methods. You can either have three. You can have a body powered device, which will use some type of harness system. And so you would use a motion like biscapular abduction or glenohumeral flexion to get the hook to either open or close, or the hand to open or close. Or you can have myoelectric control, which would rely on those muscle signals. So if you told the child to imagine that they were going to extend their wrist, then the hand would open. And if they flex the wrist, then the hand would close. But that's where procedures like the targeted muscle reinnervation are important, because if you have multiple signals, they can actually read multi-digit articulation. So that's as they get older, then you have the multi-articulating hands and they'd have independent digit control. And then they can do cool things like rotate wrists and independently move each finger. So that's where you're pre-planning, you know, when they're say 4 or 5, they're probably not going to have a multi-articulating hand because they're not going to understand how to do all of those different movements. But as they get older and they move into something like office work where they need to manipulate certain things with fine motor skills, you would look at that. I'm not sure how familiar you guys are with the process of actually getting a prosthesis, so I'm going to quickly go through that. We always start with a physician referral. The patient is sent over to us with a referral for some type of prosthetic care. After that, we evaluate this patient. We see what they want to do, what they need to do, what their current prosthesis maybe is not allowing them to do. And we talk to both the child and the family. That's important to get both sides, because sometimes parents will obviously take over that appointment. And kids have different wants than sometimes what their parents want. After we do our evaluation, we're picking all of our componentry and we're sending back to the doctors a detailed prescription for them to sign with every single line item of all of the different prosthetic components. We then take a cast. Nothing we do in prosthetics is off the shelf. So all of those sockets are completely custom. We can't just grab something and put it on a kid. And depending on the clinician, there are multiple ways to get an impression. You can either hand cast with fiberglass or plaster, or some people use digital capture tools. After that, there's a check socket, which like on the far right-hand side is a clear plastic version of our prosthesis. And this little girl was being silly and wanted her foot turned sideways, but it allows us to pick where we want that foot. We actually have the child walk or run or do activities in the office. We can make sure that things fit, that there's no pain. That clear plastic is really moldable. So if we need to make something tighter or looser, we can adjust it while it's clear and plastic. And we can also move that foot around quite a bit. After that, our technicians will make a definitive product out of carbon fiber and acrylic resin. It makes it really lightweight and more durable. And that child will come in for a delivery appointment. And then after that, we have regular follow-up. Depending on how old they are and what activities they participate in, that could be anywhere from every month to every 3 months to every 6 months. No child should be going for longer than 6 months without following up with us because they do grow. And so as they grow, if we're not adjusting that prosthesis to keep track of their pelvis, we can develop other things like scoliosis. We can also have issues like bony overgrowth that aren't looked at, and then they aren't sent back in a timely manner, and then we have emergency surgeries. As we're fitting these kids, we're really thinking about how old they are, what they're doing, and what we need to make based on that. So our first prosthetic fitting in lower extremity is going to be at pull to stand. For upper extremity, it's fit to sit. There are some hospital systems that are fitting way earlier than fit to sit. They're actually fitting at about 4 weeks old. So, but our literature for prosthetics says fit to sit for upper extremity. When they're teeny tiny like this, we're looking for, they're going to have rapid linear growth. They're also going to grow circumferentially, but a lot of times kids will grow out of their sockets linearly before they grow circumferentially. They also spend a ton of time on the floor. So we need to allow full range of motion. They're not going to be able to pull to stand and get their knee tucked all the way underneath them if we've got things too high. So we want to make that so that they're super functional. This is kind of a cute video. Let's see if it'll play. There it goes. So this is one of my kiddos, and this was some of her first steps. And so then as we get a little bit older, and we're in that 1 to 3 year age range, we have all sorts of changes in terms of varum and valgus at the knee joint. We also have changes in internal and external toe rotation. So having a modular design that allows us to change the prosthesis as they change is really important. From 3 to 6 in that active early school year age, it's got to be durable. Kids are crawling on playgrounds, they are jumping off of monkey bars. And if we think about the amount of impact that a kid swinging on monkey bars and jumping down is, it'd be if we were swinging from the ceiling and jumping down. It's a ton of impact. So it's got to be just as durable as they are. I tell all of my families, regardless of whether a component isn't necessarily waterproof or not, or it can do this or that, like let the kids be kids, let them do whatever they want to do. And if they break something, I will fix it. I'm not going to say like, you cannot go to the splash pad with your friends because your prosthesis might get damaged. Like, go have fun. We can fix anything that you break. That is the great part about having artificial parts, you know? As they get a little bit older, that 7 to 12 year age range is where we really start to see limitations that their prosthesis imposes on them. And so when they come back, that's the important discussion is what has your prosthesis limited you from doing and how can we change that? They're starting to get into sports, and a lot of these kids don't participate in necessarily adaptive sports. They're playing able-bodied sports with their peers, and they want to be able to keep up with their peers. So we do offer and we tell them about different adaptive accommodations, but if they want to play able-bodied basketball, we need to be able to keep them up and get them going. Kind of like this kiddo, he's now in high school and he's playing on his high school team. And then 13 to 18 brings a whole different unique set of challenges. So you have like a very broad spectrum. You have all of the girls in high school that want to go to high school dances and they want to wear high heels. And these prosthetic feet are not necessarily all made for that. So how can we accommodate that one night where they want to wear the heels and not necessarily wear it all of the other times? You also have covers coming into play. Sometimes this is the age where they want to blend in and they don't want to stand out. So all of the fun designs that they were picking all over their legs are no longer going to be that. And they want a full cosmetic cover, which we discuss with them as an option, but they are still growing. So getting to those components and lengthening things then becomes an issue. And if we do have to do that, that cover is not going to be so pretty. This is also competitive sport ages. So some girls want to have their pretty leg, but they also want to play basketball. So now you're looking at multiple devices. If you ever get into a situation like that, the great thing about that PEDS realm is grants are available, and we can always get grants for specific sports items because insurances do not cover anything that is going to be a non-everyday leg. So if it is going to be a recreational leg, insurance will not pay for it at this point. Hopefully in the next year or two, Arizona is going to participate in so everybody can move, which would then open the door to a secondary device for sports. Like Dr. Belthur talked about, we have different prosthetic complications. So obviously we have limb length inequality and growth. We're always accommodating that. We have different fit issues as they grow because you don't grow equally. You know, proximally you might get bigger in AK and distally you might taper down. So we're constantly adjusting. We can pad sockets, we can add socks, and then at some point when it no longer fits, we just need to replace it. Phantom limb sensation is a thing in the pediatric realm. It's not as common as adults, but it is there. Terminal overgrowth is very common, and unless certain procedures like limb capping are done, once it occurs once, it occurs pretty frequently. And so we're looking at sometimes creating sockets to allow time between those revisions so they're not having them every year. And then in Arizona, dermatologic complications are huge. It is hot. And you are wearing a silicone liner, which retains heat. So now it is even hotter and it's sweaty. So you have fungal rash issues. You have issues with ingrown hairs, you have heat rash issues, and we have to tackle those with the family. And then lastly, you have body image and acceptance issues. So if you can get a child to participate in any type of adaptive sport, or you can keep them active, it sometimes helps with that, but also a big referral would be to psychology when we get to that problem.
All right, so we'll move into the roles of rehabilitation as far as this team goes. Like I said before, I work in outpatient, so I'll primarily focus on the outpatient role of therapies. But there is a significant need, as Jillian mentioned, especially like preoperatively, and the role that our inpatient rehabilitation plays as well. Also, as a physical therapist, I'll focus on that since that's my scope, but we work closely with our occupational therapist colleagues in the rehabilitation world as well. So starting with the ICF framework, which I'm sure most, if not all of you guys are familiar with, and as it relates to the F words, this is the center of the focus as we're developing plan of cares for all of our patients. And as it was alluded to by all of our team members here, really that important aspect of future. So we're not only worried about what specific goals that are presented at the time, but how that's going to change throughout their lifespan as they continue to grow and develop. So some key components of the assessment, and I kept this pretty brief as far as our multidisciplinary clinic goes. We're all looking at specific things. I'll also do part of the skin assessment and assessment of the residual limb, assessing pain and more specifically how that relates to function, looking at range of motion and assessing for contractures for the patients that we're following up over time in clinic, measuring their ongoing contractures and trying to mitigate risk of development of further contracture, looking at strength, whether that's through manual muscle testing if appropriate, but also looking at functional strength can tell us a lot about their specific needs at that time. Looking at balance, that's both static and dynamic in both seated and standing. And then a big bulk of what we're looking at in our clinic too is overall mobility, how they're moving on the mat table, how they're getting on and off the table, in and out of their chairs, and the big focus as well is doing the gait assessment. That ties in a lot of the things that we're all looking at with Jillian, looking at how the prosthetic device might be fitting, looking at the strength impairments or range of motion impairments or pain that might be contributing to compensatory gait patterns. So that's when we all kind of put our heads together with what design they might need for their next prosthetic device. And then always just looking at equipment needs, again, back to anticipating the future, not only seeing what they have currently as far as mobility aids go, but what they might need looking to the future in their desired activities. So getting into a little bit more of the intervention, again, this is going to look really different patient to patient with the ICF model in mind. It's going to vary specifically to their goals, but always incorporating some amount of range of motion.
We know our patients with above knee amputees tend to be the most contracted in their hip abductors, hip flexors, external rotators. So really trying to target range of motion and preserving range of motion of those muscle groups. Our patients who are below knee amputees tend to have more hip flexion and knee flexion contractures too. So taking that into account. Strengthening, huge part of what we do, obviously, but that looks so different for each patient. And their age and their participation in what they're doing. Gait or weight bearing progressions, as you can see in the photo, we have a patient who is a right lower extremity prosthetic user. So working on just off weighting that left lower extremity so that we can get some weight shifting into the prosthetic side, giving more proprioceptive input, weight shifting, incorporating a reach just to try to really give him awareness over that side as he's starting to pull up to stand and stand. And then following that, as he continues to grow with different gait training progressions, whether that's introducing appropriate assistive devices throughout whatever phase of rehabilitation they're at, and continuing to adjust that as they grow. Always keeping in mind their cardiovascular fitness and endurance. We know the more proximal the level of the amputation, the higher energy expenditure we're going to demand from those kiddos. So keeping that in mind and maybe introducing appropriate activity pacing strategies or different things that can help them with pacing a little bit easier. Looking at balance, again, seated, standing, static, dynamic. Overall, looking at mobility, which is a huge component, bed, wheelchair, ambulation, however they're moving around through space and whatever their desired way to move through space is, making sure we're focusing on that. And then focusing a lot on their functional activities. We know that fall risks are a little bit higher in our patients who are prosthetic users. So not only helping them with preventing falls, but then also trying to help with fall training and mitigating risk of injury with falls. And then teaching like floor to stand transfers so that they can get back up more independently after a fall. Stairs and curbs, especially if that's in the home or the school environment. Transfer training, we'll have families bring up their vehicles if they want to work on car transfers or simulate different transfers in our gym as well. Caregiver education, obviously a huge part of all of the sessions that we're doing. And then ongoing assessment of their equipment needs and adapting and updating home exercise programs as we go to incorporate carryover at home.
So we try to use the shared decision-making model. This is one, the share approach that we use. And then where S stands for you seek the families and the patient's participation if they're old enough. And then you help them evaluate the different options, like I said, limb reconstruction, prosthetic reconstruction options. And then you help them or ask them what are their values and preferences. And then later help them reach a decision about which option they want to go for. And finally, evaluate their decision. So that's the model we use where we involve the parents and families. So now we are going to jump to the cases. So this is a 3-year-old girl who has arthrogryposis, who presented with, like a short left femur with hip dislocation, severe knee flexion contracture of more than 100 degrees, and then also had severe foot deformities in both her feet. So so she had a lot of problems. So when I talked to the family, the mother, she wanted one surgery and did not want multiple surgeries. So after doing the shared decision making, and then I sent her to her prosthetist Jillian, and then she talked to the family as well. And then we ultimately decided to do like a SIM amputation on the right side, and then we corrected the knee flexion contracture by doing a knee fusion and then a SIM amputation as well on the left side so as to equalize the leg length. And then we ignored the hip dislocation, and then I'll let a prosthetist take over from here.
So prosthetically, she's really challenging because they've been inconsistent with outpatient physical therapy where they were going. And then in addition to that, outpatient therapist isn't familiar with prosthetics really. So the outpatient physical therapist isn't familiar with prosthetics. We did have some problems with balance, and so the original design to this had a functional knee joint that bent. But because of her balance challenges, we've gotten rid of that to just get her nice and stable and get her up. And our hope is to move her back to physical therapy here, where there's a little bit more experience and they can work on developing certain muscle patterns, because she likes to stand with knee flexion on one side, and we don't want to necessarily make our design to accommodate that at this age. But really her big goal is she's going to be starting a daycare program soon, and her mom wants a very simple prosthetic design that daycare would be able to get on and off, and she'd be able to interact with her peers. So keeping things nice and simple.
Yeah, from a rehabilitation standpoint, she has been starting hand therapy here, but like Jillian said, trying to get back into physical therapy here as well to address some of those big things back to the ICF model. Playing with siblings in the backyard is a huge goal of hers. So looking at things like gait training over varied terrains and getting on and off the floor, especially knowing that she might be starting daycare soon. So those would be components.
Okay, this is patient number 2. So he presented with the gunshot wound, like I showed you in the indications. So they tried to do a reconstruction, but he had already developed compartment syndrome in his leg and his muscles were dead. So he ended up with a knee disarticulation. So he used to work in construction before, wanted to work in construction. So we made sure that we had to initially do a guillotine amputation for the muscles and everything to heal, because there was some infection. Then after that, we went and completed the knee disarticulation with the purpose of giving him a nice residual limb with a good healthy stump. And then after that, we consulted like Jillian.
So this patient is actually not one of my patients. I am now helping coordinate care for him. This is really where clinic shines. So this patient came back into clinic with a request from the current treating prosthetist to revise the knee disarticulation to a transfem due to pain. She was under the impression that there were bullet fragments causing pain fit issues at certain spots of his femur. And so when imaging was done, there are no fragments in that area, and that pain is a result of a poor prosthetic fit. So we were able to look at that, evaluate that, and not necessarily revise and do another surgery when it's not needed. So we're going to go back and remake this prosthesis to get him back. He actually has discontinued working in construction due to pain. And so we all want to collaborate to get him back to where he was functionally prior.
And then as far as rehabilitation goes, again, I haven't worked with this patient specifically, but in discussing with the team, we know the pain management is going to be huge, whether that's mirror therapy or graded desensitization, or however we can best meet his pain needs at this time. And then looking to function and participation, he wants to complete a GED, maybe get back to working. So those would all be important factors that we'd want to look at as well.
All right, this patient Dr. Belthur mentioned in one of the earlier slides too, but this was an 8-year-old previously healthy girl who presented to the ED with leg pain and fevers, went on to have group A strep, bacteremia, toxic shock, and multi-system involvement. She had to be put on ECMO, developed extensive necrosis of all 4 extremities. So it was a pretty, traumatic experience for her, for the family. There were some, language and cultural issues that we definitely had to, address during her stay and before her amputations. We had psychology involved with her care during her hospital stay. And ultimately, it was decided between, all the teams involved that the best course of action for her would be bilateral knee disarticulations, which Dr. Belthur and I performed together, and then bilateral transradial amputations, which Dr. Hassan and Dr. King did, as well as targeted muscle reinnervation on the upper extremities too. This is just a video of her most recently with her prosthetics fit. We'll let Jillian, talk a little bit more about that. But ultimately it was a, great outcome for something that was a very difficult, course for both her and the family.
So this little girl is pretty amazing. This is probably about 5 weeks after she got a set of stubbies and she's trying to walk independently. Her parents are saying that like they're actually trying to slow her down because they can't keep up with all the things she's doing. She is a very proficient upper extremity user. So in all of these photos, she's not wearing them, but within a few weeks of her getting bilateral upper extremity hooks, you could hold a sticker in front of her and she could grab the sticker with one hook, transfer, let go, and grab it with the other hook, which is super fine motor skills and very impressive. We've actually been able to collaborate and get her in contact with an adult user who is a quadrilateral amputee who presents exactly like her, so that the family can ask questions and ask how she does certain activities. This lady has 3 children. She had 1 child before her amputations and then 2 after. And so she takes care of all of her kids. She has a husband, but she does all of her tasks independently. And so the family really got to, and she speaks Spanish, which is huge. But they got to ask lots of questions about what daily life looks like for her later in life.
As Jillian mentioned, she's progressing super quickly. She's getting ongoing PT and OT twice weekly at this time. She leaves every session like dripping in sweat. She works so hard. And I asked her yesterday what's like one thing she wants to make sure that you guys all know about her. It's that she loves playing with her siblings. So we're working on a lot of just progressions of balance and strengthening, getting on and off the floor, picking up toys from the floor. And OT is focusing a lot on bimanual movements with her hooks and able to pick up the stickers and the toys like Jillian was mentioning, especially in preparation for return to school.
One thing I would like to say, I'm sure a lot of people were involved in our care in the hospital. And at one point we even discussed, is it even worthwhile, saving her limbs because it's all limbs. And then, but looking at her now, I mean, there's no, there's no doubt in my mind, at least, that as long as the cognitive development is there and then the motivation is there and the family support is there, I think we did the right thing for her. Yeah.
All right, and then this is a patient, adult patient now, 19-year-old, that presented to my clinic, that basically requesting a left lower extremity amputation. He had a history of polytrauma at age 3 with multiple fractures, lumbosacral nerve root avulsions, which basically left him with no motor or sensory function in his left lower extremity. So this is actually a preoperative video from our gait lab that basically just shows he kind of just drags that leg around. Despite that, he was still very active. He liked hiking. And so really just came in saying, I feel like I'm just dragging this limb around. Can you do something to help me get it off? And so this is one where I really relied heavily on, Jillian's input as well. She actually had him set it up for him to meet with another patient who had previously had a hip disarticulation. And so we went ahead and did a hip disarticulation. These pictures up top are showing those nerve transfers that I talked about in the previous slide, where we made those little nerve tacos here, just wrapping them in muscle. And he's just 4 weeks out from his surgery now. His wound has healed well, and he just recently saw Jillian in clinic as well.
So I think this is really like a good case of collaboration. Originally, the discussion had been to do a knee disarticulation, but he has no active hip flexion or hip extension. So for him, a prosthesis would have been more like a kickstand. He would have still relied on upper extremity crutches to utilize that prosthesis because he wouldn't be able to pull the knee into extension. So we would have just had a manual lock knee. He would have had to manually unlock the knee to sit, and then in standing, he could weight transfer because it would hold, but it wouldn't help him necessarily for walking. He'd still have a pretty similar gait to what he did with his crutches. So then we discussed functionally, if his goal was to return to walking without assistive devices, then a hip disarticulation would be a better option. And that's what he and his family elected to do. We're hopefully going to cast him and get him up in the next week is our goal. So that'll be really exciting.
And as far as rehabilitation's needs go, like they said, he's a relatively new amputee. So the road ahead would look like getting back to weight bearing with whatever prosthetic device he might have. Knowing that hiking was a huge factor in choosing to do the level of amputation that he had, then we'd want to start eventually working into higher levels of activity as well. All right, so just to start summing up here, why do we all look at this from different lenses? It's with the idea and the goal to impact their function and quality of life. by restoring function and form, which thereby helps improve quality of life and well-being and enhances their ability to participate in the things that matter to them. Camp No Limits is a cool way to kind of put this all into practice as well. I volunteered with the camp in September of last year. Jillian's really involved with it as well. It's a national nonprofit organization that provides camps nationwide to kids with limb loss and limb differences. A big part of the camp is adaptive recreational activities. So we did things like swimming and rock climbing, basketball, dancing. But then a really cool aspect too is there's mentorship opportunities for both the patients and the parents in different breakout groups. And then as always, we're assessing our outcomes with various outcome measures. There's a variety of objective measures, but we'll focus on just a few of the subjective measures. We have the Pediatric Quality of Life Inventory, which looks at domains such as the physical, emotional, social, and school functioning sections. One I'll use commonly in outpatient is the patient-specific functional scale. This is a subjective report where patients identify activities that are important to them and they're rating their perceived ability to participate in said activities. And we're looking at that score, how it changes over the course of treatment. Another common one we have is the Pediatric Outcomes Data Collection Instrument, or the PODC, which you guys might be familiar with. And that's also looking at health-related quality of life over 6 domains.
So these are some resources for patients and families. I'm not going to go through it for purposes of time, but these are the take-home points. So essentially, prosthetic reconstruction surgery, as well as the multidisciplinary approach, is very effective in optimizing, children and young adults' function, as well as restoring their quality of life. And a multidisciplinary approach, the ensemble approach, is good to develop a well-thought-out, patient-centered plan. So, but long-term follow-up to skeletal maturity is essential. We leave our contact details here, and we're happy to take questions. And these are some key references if residents or anybody is interested. Thank you for listening. Okay.
Great talk, everyone. You mentioned some of the myoelectric prosthetic, the upper extremity mindfoot control. Is that kind of the pinnacle technology for
Repeat.
Oh, is myoelectric control the pinnacle of technology for upper extremity? Yes. And so obviously with all of like the military upgrades and all of the research behind that, that's coming down to the consumer level now. And so before, all of that like multi-articulating hand motion was just military. And now consumers can have that, especially with the targeted muscle reinnervation surgeries. So there's pattern recognition, and like they can just think about moving this finger, and then the pattern has like say 16 to 32 sensors, and it can read that, and then it will make just that single digit move. So not just having like, the cookie cruncher hand that opens and closes. You can also with that have control of how much compression you're putting through that finger, so you can, not crush an egg or crush a cup.
Question also about the prosthetics. I feel like this industry of prosthetics is quite expansive and everyone's trying to do something better and more technologically advanced. Everything comes with a price tag. I even saw a prosthetic hand pitched on Shark Tank recently. So it's something that is, people are interested in. How do you decide? I saw you listed the payer when you're talking about each of your cases. How does that affect what people can get? And what about families that want to do something that's maybe a little bit beyond what is on your sort of standard list of prosthetics?
So honestly, within the pediatric realm, the payers will pay for pretty much anything, except for in upper extremity, the multi-articulating hands. That gets a little bit tricky. But for lower extremity, like your carbon feet, all of the Medicaid programs will cover carbon feet. And up until 21, they'll actually cover microprocessor knees for kids. After 21, they no longer cover that on Medicaid. But if parents want to cash pay, they can cash pay. And usually the only cash pay situations are going to be sport specific devices. But again, we'd usually go through grants. A lot of times with kids, though, we're thinking like when they're really, really young and we know they're going to be running through things all the time, you're not looking at necessarily the most expensive option because there's a high potential that their foot size increases in, 6 months to a year. So you're not going to go and pick the most expensive foot on the market just to replace it at, 2 years old and pick another $3,000 foot. Also with like all the end bearing, a lot of times in Arizona, it's great, but we can get away from liners. A liner itself costs somewhere between $500 to $1,000. So some of these kids can just be fit with socks and those are easily replaceable and the insurance and cost burden is then less. So we do keep in mind our payer and how much that's going to be reflected and how frequently we're replacing items. Okay.
You're right at 8:30. Thank you so much.
Okay.
Picture of us four standing here.
Oh, yeah. Use somebody's, should I use that one or my phone? Doesn't matter. Thank you all. Thank you. Yeah.